One of the other very important things that most patients are thinking about is their quality of life and what happens in between these treatments, and specifically what happens for patients with carcinoid syndrome. And this is something that can be more debilitating than everything else about the disease. So we wanted to have a special session on this, and also make an announcement about a new website that is coming soon. I think at lunchtime these will be placed near your seats. There's a new website coming soon called carcinoidsyndrome.org, and we have a sneak preview for the LACNETS group, carcinoid.org/sneak preview. Like I said, these will be on your seats. And this is going to specifically address some of the needs of the carcinoid syndrome patients. I'd like to introduce now Dr. Andrew Hendifar from Cedars-Sinai. And Dr. Hendifar is the head of Gastrointestinal Oncology at Cedars-Sinai. He's a medical oncology lead for the GI disease research group and is co-director of the pancreas oncology program at Cedars-Sinai. We also emphasize that there's such an importance about seeing a neuroendocrine specialist, someone who sees many patients. And Dr. Hendifar certainly sees a large volume of neuroendocrine patients. So please welcome him.
Before I start, I wanted to take this opportunity to thank Giovanna for another amazing conference. I'm always amazed at how hard she works and how much she does to support this effort, and I feel like this year is when we can kind of see all the fruits of that labor, and it's amazing. Okay, so today I'll be talking about carcinoid syndrome. We have some interesting and new, exciting developments in this disease space. So I'm going to try to keep to the basics so I don't bore everyone here. What's really interesting about the word carcinoid is that its definition has kind of been changing, but we should probably start in the beginning, and a shout out to our German colleagues, for Dr. Siegfried Orbendorfer, who was the pathologist who identified this tumor. He called it a carcinoid because it seemed like a benign tumor that had a malignant appearance. But fast forward over 100 years, and the classifications have been changing quite a bit. But when we say carcinoid syndrome, what we're talking about are neuroendocrine tumors that produce too much serotonin. You're going to hear this a lot, but although we seem like it's a rare disease, this is a very important disease. Neuroendocrine tumors, there's a lot of meanings to it. There are a lot of different diseases encompassed by this term. But as you can see from the people in this room, it's actually not a rare disease anymore. And the identification of this disease is growing rapidly. Now, regarding carcinoid syndrome, I don't know if Dr. Halperin is here. He should be here later today, but he published a great paper this past year looking at the incidence of carcinoid syndrome in the SEER Medicare database. What we're finding is that the incidence over the last 20 years seems to have increased from about 10% to now it's closer to 20% of patients with neuroendocrine tumors have carcinoid syndrome. That's based on the SEER database. So, now where do NETs come from? Well, they come from all different areas. We've kind of gone over this. But I want to focus right now on what are functional neuroendocrine tumors. So functional neuroendocrine tumors are neuroendocrine tumors that produce a hormone that cause symptoms to the patients. And carcinoid syndrome is the most common of those different functional syndromes. Now, pancreatic neuroendocrine tumors are notorious for creating functional syndromes. You see here, you have a gastrinoma, insulinoma, there are all kinds of things that we have to check for. Even lung tumors can produce ACTH and get what you call Cushing's syndrome. So functional syndromes are important for all neuroendocrine tumors, but again, today we're going to focus on carcinoid syndrome from the midgut tumors. So again, I'm going to keep repeating this because I think this is so important to what we're doing. So two main things that we have to focus on. One is, where is the primary site? And again, two, what is the functionality? Is there a functional syndrome, or is it clinically silent? Now, why that's important is because that will determine a lot of what Dr. Singh and what Dr. Nissen does. Also, what I would do as a medical oncologist. So these two facts are essential. When we talk about carcinoid syndrome, this is what we think about. Maybe some of the people in here don't have it or haven't seen a patient with it, but it can be quite distressing. It's not just turning a little red and no big deal. It can be associated with embarrassing moments, heightened anxiety, blood pressure changes, and overall just not feeling very good. And of course there's diarrhea. And diarrhea, if you have 1 or 2 episodes of diarrhea a day, okay, life goes on. But if you have several episodes of diarrhea a day, then going to the movies becomes an issue, leaving the house becomes an issue, and it can be very debilitating. This is a complicated slide, I'm sorry, but this is serotonin metabolism. I have to learn about it now because we have all these really interesting new medications. But if you look here, the tumors are producing tryptophan, and it works its way down through different enzymatic reactions to serotonin. And now we have a medicine that works on this part. It's a tryptophan hydroxylase inhibitor. So this is important to understand. The tumors are producing the tryptophan, hydroxytryptophan. These become degraded or metabolized into serotonin, and that's causing the syndrome. So thanks to all the PhDs in the audience who are studying these diseases, who have allowed new medications to come, and we'll talk about that later. So what are the symptoms of carcinoid syndrome? So let's start with the most common. There's the flushing. So you can see here, this is the percentage of patients who have these symptoms. So flushing, again, a flush once a day or once a week or once a month is not a big deal, but often it's more, commonly it's more often than that, and that can cause problems. There's diarrhea. We talked about those. Now, carcinoid heart disease is a very important issue because it's often silent. You don't know that you have a heart problem until the heart problem is really bad. So we have to make sure that we screen the patients. They need to get echocardiograms and heart tests if they have the carcinoid syndrome. And there are other issues here also. I don't have time to talk about everything. Now I would like to talk about something that's near and dear to what I'm interested in investigating a little bit more, are some of the emotional and psychiatric manifestations of carcinoid disease. One being neurosis, which is where anxiety can overcome somebody and change their behavior. So I have patients who come in when they have uncontrolled carcinoid syndrome, and they're definitely not themselves. And you can't really describe it when you meet them, or the family members have a hard time describing what's wrong with them. And sometimes it can get so bad that they can be also altered, seem disorganized and confused. When I meet the patients, it's always like, thank God they brought their significant other, because I know whatever I'm telling them, in about 5 minutes, they're not going to remember it. Or I'll take copious notes. Everything has to be written down, because when they leave the room, it's like the visit almost didn't happen. But once you control the carcinoid syndrome, the real personality comes back to the forefront. This is also interesting, is that carcinoid heart disease is very important. It's one of the manifestations of carcinoid disease. And because we always detect it too late, it's sometimes impairs management. So if you have somebody who has heart failure, then Dr. Singh and Dr. Nissen is like, oh my God, the patient has heart failure now, they're not a good surgical candidate. So in this study, they took 15 patients who had carcinoid heart disease and liver mets, and they found that if you replaced the heart valves, these patients could go on and would improve. So here you see fatigue, shortness of breath, edema, pre-valve replacement. This is after valve replacement. So they gave these patients new heart valves. They felt better. They went on to surgery, and they did just as well as patients without carcinoid heart disease. So again, this is important to understand, pick up early and treat. And now they've done lots of studies also looking at the cognitive impairment I'm talking about. Now this is not commonly discussed, but again, something that I'm just very interested in. You can see that patients who have carcinoid heart disease, they have cognitive issues. And for the doctors, it's not as important as it is for the patients, right? I mean, doctors are really focused on physical ailments, but the cognitive ones are the ones that the patients really are upset about. They're not able to function as well at work. They're not able to be good partners and parents. And they're not, they're not enjoying their time with their friends. So these are the types of things. So what I'm really interested in looking at, so for example here, visual memory is diminished, complex figure, and this kind of neuropsychological testing is done by a specialist. It's usually a psychiatrist, and we call it neuropsych testing. So when you look at patients with carcinoid heart disease, they have issues. They really do. And this is a study from a surgical group published in the Annals of Surgery a couple years ago. So currently what we're doing is looking and doing neuropsychiatric testing in our patients, trying to kind of untangle what it is that's happening. And also, I think the next step for us as a group is to really see if treating carcinoid heart disease can improve these cognitive issues, because I think that might be a pathway to the future for new medications for this problem. So again, one of the themes for today is that we have to treat the tumors, and if you have this syndrome, we have to treat the syndrome. Sometimes you can treat both at the same time. Sometimes you have to treat them separately, okay? So the cornerstone of the medical oncologist treatment of carcinoid syndrome is somatostatin analogs. So we use this to control the symptoms of carcinoid syndrome, including flushing. It can also treat functional pancreatic tumors. And even a big bonus is that the recent literature supports that giving patients somatostatin analogs, the appropriate patients, somatostatin analogs, helps control the tumor as well. So not only do you treat the carcinoid syndrome, but you stop the tumor from growing. And this is supported by all the major societies and guidelines. Now, it's hard to believe that over 30 years ago, this paper was published looking at octreotide 3 times a day in patients with carcinoid syndrome. And surprisingly, 22 out of 25 had improvements in flushing and diarrhea. 18 out of 25 had a decrease in urinary 5-HIAA. So what stands out to me as a physician is not often that I give a medicine to a patient, and I'm not that sure it's going to work. So this is 72% is a even higher number of 22 out of 25. That's like an A for a medicine as far as medicines go. And over the years, now we have long-acting shots, right? You don't have to give it 3 times a day anymore. You give it 28 days. So we have sandostatin. And we also have now lanreotide, also having papers and data showing that it works. So recently, a really, really neat medicine based on the serotonin metabolism I showed you before is a medicine called telotrestat ethyl. It's a serotonin synthesis inhibitor. Okay, it's a tryptophan hydroxylase inhibitor more specifically. And if you can remember back to the diagram I showed you, it blocks the tryptophan from becoming serotonin. I think it's really smart. That's really neat. Another good thing about the medicine is that it looks like it doesn't affect serotonin levels in the brain, so hopefully it doesn't cause any, depression or any other kinds of side effects like that. So a recent phase 3 study was published, and this drug is now approved for use over the past year. I don't know if there's anybody who's been prescribed this medicine. Not here, okay. So we've prescribed it to several patients in our clinic. And it's basically indicated for patients who have carcinoid syndrome and the somatostatin analog therapies alone are unable to control it. So in this study, patients were randomized between placebo and 2 different doses. And the primary endpoint, which was also a very smart thing, was they didn't look at patients live longer or not. They looked at whether or not the bowel movement levels were improved. That was the primary endpoint, was a reduction in the number of bowel movements. And here you see in patients who received the different doses of medications, over here, had a response. So about 40 to 50% of patients had improvement in the number of bowel movements, and they met the primary endpoint. They also found that the urinary 5-HIAA level was diminished in these patients as well. So again, 40% of the patients receiving telotrestat versus 20% of the placebo responded. And they overall did really well. So let's just summarize. Keep it basic. Carcinoid syndrome can lead to significant side effects. And we need to focus on controlling the syndrome as well as the tumor. Sometimes we can do them at the same time, sometimes separately. Don't forget to check if you have carcinoid syndrome. Now, if you don't have carcinoid syndrome, this heart function is fine. You don't have to worry about it as much. although you could have silent syndrome. I don't want to get into it and get anyone nervous. I know after I give a talk like this, everybody wants to get an echocardiogram. I don't think that's the point of this. It's just that if you have the carcinoid syndrome, you need to get it checked out. And that somatostatin analog therapy is the backbone medical treatment. And that in addition, I'm very pleased to say that we have a new treatment for this disease, telotrestat ethyl, which was recently approved. So thank you so much for your attention.